I'm going to now shift to our next presentation, and I think this will introduce an interesting additional twist on our conversation in that, and this has been touched on a little bit, but technology is playing an increasing role in the ability to provide access. And I think this may also not only be a tool to support access, but may also start to bend or reshape our thinking about what we mean by access. And for this next talk, I'm thrilled that we have Dr. S2 Yee, who is the Chief Deputy Director and Chief Medical Officer for the Los Angeles County Department of Health Services. He's working there and helping to lead the nation's largest county health system with regard to providing access, and has a very provocative title for his talk: Access, Not Enough, Yet Too Much. So, Dr. Yee, thank you for your comments today.
Thanks, Andy, and thank you to the Academy. Living in Los Angeles, I've always wanted to say that. Disclosures, I'm a retired faculty from UCSF, and I'm an external advisor to Rubicon MD. Listening to Lillian and John, I was just blown away by the theory, how deeply they were able to look into the conceptualization and theory of access to care. I'm going to present something that I think is a lot more humble and pragmatic. And it's really, how do we think about access? And is the question one of having more access, or as we've tried to focus on, how do we provide the right health care at the right time? A lot of this work has come from San Francisco and Los Angeles's healthcare safety net, the county health systems, where we've needed to try to balance system versus individual patient approaches. We've worked in a capitated safety net health system, and we focused on outpatient specialty care as our model. There are a lot of commonalities between county health systems and the VA, particularly in the capitated safety net system, the employed physician model, and outpatient specialty care demands in both systems. The two pieces that we've really focused on are right care and right time. And so I'd like to better define what right care means. So we've really focused on providing the appropriate care, whether that's measured both by outcomes or by what we define as a patient need, or the patient's perception of need, or the primary care provider's perception of need. We believe that right care is always better than more care. And I think emerging evidence in radiology and other areas have demonstrated that more care can actually be harmful in addition to be wasteful in settings where we have limited resources. So we've really focused on what is the right care. So how do we define right care? We've defined right care as care where there's efficacy data showing that the benefits outweigh the risks. We don't believe that it makes very much sense to provide care if the risks are going to outweigh the benefits. We also believe that it's important to provide care that's demonstrably demonstrable, has demonstrable real-world effectiveness. As you know, a lot of care we can provide in tightly controlled studies that shows benefit, but in the real world, we can't provide that benefit either because of compliance issues or because the real world is a challenging place. So we've focused on care that we can provide effectively. We've also tried to individualize the care for the patient in the situation, as has been discussed previously here. It's very important to provide this patient-centered care. Because we're in a system where providing more capacity is challenging, we've really tried to take the disruptive innovation approach to how we solve these problems. So some of the solutions that we've brought to this question of providing right care are the conception and implementation of eConsult, a summary of what we've done in the past. I published with Alice Chen and Lisa Murphy in New England Journal of Medicine 2013. And this is an iterative electronic dialogue between the primary care provider and the specialist. It's asynchronous, and it informs a patient's care. It's how we attempt to use the expertise provided by the primary care provider who knows the patient best because of the continuity, because they're aware of the patient desires and they're aware of the patient's social determinants, as well as the expertise of the specialist who would have the most understanding of the right care for that particular specialty care need. And by having this dialogue between the specialist and the primary care provider, we're able to determine what the right care is, in addition to the right time, who's the right provider to provide that care, and where the right location is. That's one of the innovations that we've put in place both in San Francisco and in Los Angeles in order to determine what the right care is. As it turns out, a fairly robust number around the country where eConsult has been used is that quality patient, especially patient care, can be provided without having the patient come to see us face-to-face or even in real-time video, at least a third of the time in most instances. We've also developed a concept called the expected practice, and Monica Soni, Paul Gibbony, and I published that in JAMA in 2016. And this is a concept which we have proposed and implemented in Los Angeles, which is neither policy nor guideline, but represents the negotiated, most effective clinical practice, and it permits a reduction in variance in general, but it also permits variance by a particular provider in a particular time. So we have brought to bear both eConsult and expected practices to both determine what the right care is for that patient using these active and passive tools. We've also focused on right time. In an era where we're spending a lot of time thinking about precision in terms of precision medicine, a lot of genetics work, a lot of tailoring therapies, it's occurred to us that we have not, as a society, thought about precision in scheduling of access of care. And so we believe that right time is just as important as right care. And right time would mean that we provide care at the precise moment, if we can get there, that the patient should have the care, not too early, not too late. We have proposed that access standards, like in the ACA, where you need to see a patient within I think is 30 days for specialty care, or in California where the Department of Managed Care tells us that people have to see patients in specialty care within 15 days. We believe that these kinds of arbitrary, standardized access standards can waste and harm. Third next available in our minds is too rigid, often too vague. A lot of care should be offered before, third next available should be before 2 weeks or after 2 weeks, for example. Obviously, if care is too late, you can miss diagnoses and you can miss the opportunity to treat. And if care is too early, it can be wasteful and possibly harm the patient. So the solution that we've come up with to try to get to right care is what we call precision scheduling. This is in submission right now as a manuscript. In this era of precision medicine, we created and implemented this concept of precision scheduling. This is the idea of timing a specialty visit to the individualized need of the patient. we determine timeliness through the e-consult dialogue. So the primary care provider and specialists working together using their dual expertise or their mutual expertise determine when the patient should be seen. And the metric that we've developed for how well we're doing is what the percentage of specialty visits is that actually meets the recommended time interval that the specialist and primary care provider have decided that the patient should be seen. So I'm just going to end by saying that we believe by focusing on the appropriateness and timing of healthcare delivery that we may solve some of the perceived problems in access to care that are the focus of this workshop. Thank you very much.
Thank you so much, Dr. Yee, for that a terrific talk and really focusing in on the question of whether the global approach that we have taken to measuring timeliness needs to be made more precise based on the individual patient.